Good morning and afternoon. Welcome everyone who is joining us today for the 82nd Presidential Advisory Council on HIV/AIDS, also known as PACHA. My name is Marlene McNeese. My pronouns are she and her, and I am currently chair of PACHA. I serve as Deputy Assistant Director with the Houston Health Department, overseeing our Bureau of HIV, STI, and viral hepatitis prevention. Before we get started with the meeting today and our agenda for the next 2 days, I want to briefly define the PACHA charter, charge, and mission. PACHA provides advice, information, and recommendations to the Secretary of Health and Human Services regarding programs, policies, and research to promote effective treatment, prevention, and cure of HIV and its related syndemics. This includes the Ending the HIV Epidemic in the U.S. initiative and monitoring implementation of the updated National HIV/AIDS strategy. Through the Office of the Secretary, PACHA may also make recommendations for consideration by the Director of the White House Office of National AIDS Policy as appropriate, concerning implementation and progress in achieving strategy goals. Under the authorities given in the Presidential Memorandum and Executive Order 13703, PACHA shall contribute to the federal effort to improve HIV prevention and care. I want to emphasize just a few basic reminders for our PACHA members. PACHA must vote on recommendations during a full council meeting, like the ones we are having today and tomorrow. PACHA is solely advisory in nature, and PACHA members are special government employees, and the Hatch Act applies during PACHA duties. PACHA does not advise non-HHS agencies or Congress. PACHA is not a funder, nor the voice of one person. PACHA recommendations are just that, they are not mandates. Lastly, PACHA members should not make partisan political comments or discuss upcoming elections during PACHA duties. With that, I am excited about our agenda for the next 2 days. This virtual meeting is in direct response to much of what we have learned as a PACHA council around the global successes that could be learned from our colleagues in all parts of the world, and what can be learned from the incredible work being done to accelerate the work being done here in the U.S. Again, today we will basically go between 1 p.m. and 5:30 p.m. Eastern Time. Similar tomorrow, we will begin at 1 p.m. and go through the remainder of the afternoon, evening, and recess and adjourn at a similar time, 5 p.m. Today, I want to begin a roll call so we know who is joining us today. So PACHA roll call is facilitated expertly by our very own Carolyn Talib. She is the Executive Director of the Presidential Advisory Council on HIV/AIDS and also its designated federal officer. She is a Senior Management Analyst in the Office of Infectious Disease and HIV/AIDS Policy at Health and Human Services. Caroline, I turn it over to you for our roll call today.
Thank you so much. For our PACHA members, we'll go through the roll call and we ask that you say your organization, where you are zooming in from today, and what subcommittees you serve on. PACHA Chair Marlene McNeese.
Present. I serve as PACHA Chair and I serve on the EHE, Global Aging and Stigma subcommittees.
Guillermo Chacon.
Present, Guillermo Chacon, and serve also in the ending the HIV epidemic as a co-chair with wonderful super Shiro Tori, and at the work group under the stigma and discrimination subcommittee. Thank you.
Philip Chan.
Good afternoon, everyone. Philip Chan, he, him pronouns, coming to you from Brown University in Providence, Rhode Island. I am on the EHE work group. Thank you.
Corey Cooper. Corey Cooper. Rania Copeland.
Hello, Rania Copeland, hailing from Los Angeles. I serve as the co-chair for the Stigma and Disparity Subcommittee.
Mackenzie Copley.
Hi, everyone. My name is Mackenzie Copley. I'm the co-founder and CEO of 110 Health, an HIV screening organization in Washington, D.C. I am on the EHE committee.
Alicia Diggs.
Good afternoon, everyone. Alicia Diggs, zooming in from University of North Carolina at Chapel Hill Center for AIDS Research. I am with the Stigma and Disparities and one of the co-chairs for our Aging Subcommittee.
Jen Cates.
Hi, everybody. It's Jen Cates. I am in Washington, D.C. I'm with KFF, Senior Vice President and Director of Global Health and HIV Policy there. On PACHA, I'm a PACHA member and I'm also the co-chair of the Global Subcommittee. Thanks.
Paul Kawada. Paul Kawada.
Thought I was unmuted, sorry. So Paul Kawada, Executive Director of NMAC. NMAC is based in Washington, D.C. I am here via Montreal, Canada, and I'm on too many subcommittees.
Duvia Lozano.
Good morning, Duvia Lozano, Director for Chicanos por la Causa, Latinos Unidos contra el SIDA, zooming in from Phoenix, Arizona, and I am on the Ending the HIV Epidemic Subcommittee and also assisting with co-chairing the workforce group under our EHE committee. Thank you.
Tiami Luckett.
Good morning, everyone. Tiami Luckett coming to you from Little Rock, Arkansas. I sit on the Stigma and Disparities work group, as well as there's another part of that, the Stigma Subcommittee. Somehow I got that messed up, but y'all know what I mean.
Thank you. Thank you. Jesse Mylan. Jesse Mylan. DeAndre Moore.
Present. I'm hailing from Houston, Texas. I currently serve on the EHE subcommittee and as well as the global subcommittee. And I am here representing Prevention Access Campaign, the founding organization of U Equals You, and AVAC, AIDS Vaccine Advocacy Coalition. Thank you.
Leo Moore.
Good morning and afternoon, wherever you are. Hailing from Los Angeles, California. I'm Dr. Leo Moore, Medical Director for Clinic Services at Los Angeles County Department of Public Health, and I'm a co-chair of the Stigma and Disparities Committee. Happy to be here. Thank you.
Laura Platero.
Hello, everyone. Laura Patero, Executive Director at the Northwest Portland Area and Health Board in Portland, Oregon, and I sit on the EHE and Stigma and Disparities subcommittees.
Kayla Quimbley. Kayla Quimbley. Natalie Sanchez.
Good afternoon, everyone. This is Natalie from Los Angeles, and Director of UCLA Los Angeles Family AIDS Network, and I am on the EHE as well as the Stigma and Disparities committees.
Patrick Sullivan.
Good morning and good afternoon. I'm Patrick Sullivan. I'm a professor of infectious disease epidemiology at Emory University's Rollins School of Public Health here in Atlanta. And I have the privilege of co-chairing the global subcommittee with Dr. Jen Cates, and I serve on the EHE subcommittee as well.
Jeff Taylor. Jeff Taylor. Marvell Terry II.
Good afternoon and good morning. Marvell Terry II. I am the Senior Program Manager for Founders Concerned About AIDS. I'm calling from Atlanta, Georgia, and I serve on the Stigma and Disparities Subcommittee.
Hansel Tooks.
Hi, I am Hansel Tooks from the University of Miami, Miller School of Medicine, where I'm Professor of Medicine. I am on the EHE subcommittee, and I am co-chairing the workforce group with Duvia.
Carol Treston.
Hi, everyone. I'm Carol Treston. I'm the Executive Director of the Association of Nurses in AIDS Care. We're a global professional nursing membership organization. I'm zooming in from my kitchen in Philadelphia, and I serve on the global committee and on the workforce group from the EHE committee.
Dafina Ward.
Good afternoon, everyone. Daphina Ward. I serve as Executive Director of the Southern AIDS Coalition. We are regionally focused, striving to make a national impact to end HIV. I serve on the EHE subcommittee as well as the Stigma and Disparities subcommittee, and guiding our work group around stigma disruption. Thank you.
Daryl Wheeler.
Good afternoon. I'm Daryl Wheeler, and I'm the president at the State University of New York in New Paltz, and I serve on the Stigma and Disparities Work Group and the Stigma Disruption Subgroup.
Thank you. And CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment, or CHAC liaison, Wendy Armstrong.
Hi, I'm coming to you from Emory University and Grady Health System in Atlanta, Georgia, and I serve on the EHE committee and the workforce subcommittee.
Thank you. Now I'm going to turn it over to our federal partners. If you can say what department you're from and where you're zooming in from. Kay Hayes.
Great. Hello, everyone. Kay Hayes here in Washington, D.C., Rockville, Maryland area, Deputy Assistant Secretary for Health and Infectious Disease, also known as OIDP.
Tim Harrison.
Good afternoon and good morning. Tim Harrison, Principal Deputy Director of the Office of Infectious Disease and HIV/AIDS Policy, coming here from Washington, D.C.
Francisco Ruiz. Francisco Ruiz. Adrian Shanker. Adrian Shanker. David Johnson.
Good morning, good afternoon to all. I'm David Johnson, Deputy Assistant Secretary for Health. I am within the Office of the Assistant Secretary for Health and manage our 10 regional offices. I'm in DC today and good to see everyone.
Jonathan Merman. Jonathan Merman. Robin Blatt Fanfare.
Hi, I'm Nora Spencer-Lovell on behalf of Dr. Robin Neblett Fanfare. Apologies, she's giving a speech. She is the director of CDC's Division of HIV Prevention, and I am her Associate Director for Policy Planning, Partnership, and Communication from Atlanta, Georgia.
Thanks for being here. Lord Cheever.
Laura Cheever from the HIV/AIDS Bureau at the Health Resources and Services Administration. We administer the Ryan White HIV/AIDS program in Rockville, Maryland.
Kristen Argueta.
Hi, everyone. Kirsten Argueta. I'm a director in HHS HRSA's Bureau of Primary Health Care that oversees the health center program.
Rick Haverkate. Rick Haverkate. Kristen Roja. Kristen Roja.
Hello, this is Kristen Roja. I'm a public health advisor for HIV with SAMHSA, talking to you from Rockville, Maryland.
Diana Finzi.
Hi, everyone. I am Deanna Finzi, and I am the acting director for the Office of AIDS Research at the NIH, and I am continuing the string of people in Maryland, and I am in Bethesda, Maryland.
Thank you. Jessica Lee. Jessica Lee. Michelle Schreiber.
I'm sorry to be breaking the Maryland cycle. I'm Michelle Schreiber from Detroit, Michigan, but I'm the Deputy Director of the Center for Clinical Standards and Quality at CMS.
Rita Hartgrove. Rita Hartgrove. John Ogutumilade. John Ogutumilade. Andrea Callow.
Hi there, Andrea Callow. I am the Senior Advisor for HIV Policy at the Administration for Community Living, zooming in from ACL HQ in Washington, D.C.
Casey Knopp.
Hi, Casey Knopp with the Administration for Community Living, Program and Management Analyst in the immediate office of the Administrator, calling in from Alexandria, Virginia.
Sharonda Brown.
Good afternoon, Sharonda Brown. I'm from the Office of Infectious Disease and HIV/AIDS Policy, and I'm calling from Rockville. And I'm the Deputy Director of Operations.
Maureen Goodnow.
Hi, good afternoon, Maureen Goodenow here. I'm a senior advisor at the NIH, and I'm on detail at the Office of Infectious Disease and HIV/AIDS Policy in OASH, and I am in Washington, D.C.
Thank you. Tracy Carson.
Hi, good afternoon. My name is Tracy Carson. I'm the Acting Chief of Staff at the Bureau of Global Health Security and Diplomacy at the Department of State. You'll hear more about why we participate later today. We house and oversee the President's Emergency Plan for AIDS Relief. So it's my pleasure to bring you greetings from Ambassador John Nkengasong, who leads the Bureau and the program. Thank you.
Thank you. And that concludes our roll call. Back to you, Chair McNeese.
Thank you, Caroline. It is always my honor to have an opportunity to introduce and reintroduce Dr. Admiral Rachel Levine, who serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services after being nominated by President Joe Biden and confirmed by the U.S. Senate in 2021. As Assistant Secretary for Health, Admiral Levine fights every day to improve the health and well-being of Americans. She's working to help our nation overcome so many syndemics, including HIV, as well as most recently her launch and leadership around the syphilis response in the U.S. Admiral Levine is going to bring us a welcome and greeting in her remarks through video. So I will turn it over to the video. Thank you.
Thank you, PACHA Chair Marlene McNeese, for your kind introduction. Your dedication to PACHA is invaluable and incredibly appreciated. Greetings, Council members, federal colleagues, and community partners viewing live online from across the nation. It is an honor to welcome you to PACHA's 82nd full Council meeting. I am thrilled that today you will be discussing the United States government's global HIV response. Bidirectional learning and collaboration from United States domestic and global programs is crucial to learning effective and innovative strategies. I know that many of you were recently in Munich, Germany, attending the 25th International AIDS Conference. During AIDS 2024, Ambassador Nkengasong discussed how 25 years ago, a disease threat anywhere in the world was a disease threat everywhere in the world. Since then, PEPFAR has saved more than 25 million lives, and more than 5.5 million children have been born free of HIV. We need to sustain those gains and accelerate them so that we can bring HIV to an end as a public health threat. You will hear more about PEPFAR and the United States global HIV response, and I look forward to hearing about the discussion. I also understand that tomorrow you will have a panel discussion on the science around undetectable equals untransmittable, or U equals U. During AIDS 2022 in Montreal, Canada, the United States, along with Canada, issued a multinational U equals U call to action, which outlines strategies to ensure U equals U is fully integrated into national HIV responses to accelerate progress towards ending the HIV epidemic. Since then, Vietnam and Australia have also joined this call to action. The success of antiretroviral therapy and the indisputable evidence of U equals U has been liberating to people with HIV, transforming their social, sexual, and reproductive lives. However, significant barriers remain, such as lack of access to quality health care and social and structural factors. We need to do more to meet people where they are and ultimately increase equitable access to life-saving treatment. Our work to end the HIV epidemic extends to improving the ongoing health of people living with HIV. The world of HIV policy and medicine is ever-changing, and thanks to advocacy and progressive scientific advances, people with HIV are living longer. With that longevity comes other health issues, including end-stage diseases of the kidney, liver, heart, and lung. Organ donation saves lives, yet there is a critical shortage of organ donations for people living with and without HIV. While people living with HIV can and do continue to receive organs from HIV-negative donors, transplants from donors with HIV may reduce time on the transplant waiting list and associated costs for these recipients. At the March PACHA meeting, I shared that HHS intends to engage in the rulemaking process to propose new standards for kidney and liver transplants from donors with HIV to recipients with HIV to help increase access and reduce administrative burden. This is part of the implementation of the HIV Organ Policy Equity Act, known as the HOPE Act. Successful implementation of this proposed policy expands access to kidney and liver transplants for people with HIV. I think this work demonstrates our commitment to medical innovation and further reducing stigma and health disparities for people with HIV, for those in need of a kidney or liver transplant, as well as those people with HIV that may sign up to become donors. Since the last PACHA meeting, we have been drafting the Notice of Proposed Rulemaking. We will share it with you once it is published in the Federal Register. I invite those interested in submitting a written comment or supportive data to do so once the proposed rule has been published. As we continue to learn more about the communities that we serve and the intersectional barriers that individuals face, we must be innovative and holistic in our responses. Thank you so much for this opportunity to welcome you to PACHA's 82nd full council meeting. I am excited for an insightful next 2 days as you continue to learn and discuss ways we can make progress towards ending the HIV epidemic. I want to extend my heartfelt thanks to our PACHA members, federal partners, stakeholders, and community members. Your attention, dedication, and investment to these critically important issues saves lives and leads us to a healthier tomorrow.
Thank you so much, Admiral Levine. I don't have much to add, just wanting to dive right into what we have been planning for quite some time and are really excited about. I do want to introduce you to our global subcommittee co-chairs, Dr. Jen Cates and Dr. Patrick Sullivan. Each of them in their own right have been extraordinary in how they have added value in our domestic HIV response, as well as the work that they have done across the globe. Just giving some of you a little bit of their biography, I do want to reintroduce you to Jen, who serves as Senior Vice President and Director of Global Health and HIV Policy at Kaiser Family Foundation, where she oversees policy analysis and research focused on the U.S. government's role in global health and on the global and domestic HIV epidemics. Widely regarded as an expert in the field, she regularly publishes and presents on global health and HIV policy issues, and is particularly known for her work analyzing donor government investments in global health, assessing and mapping the U.S. government's global health architecture, programs, and funding, and tracking and analyzing major U.S. HIV programs and financing, and key trends in the HIV epidemic, an area she has been working so closely with for more than 30 years. Prior to joining Kaiser Family Foundation in 1998, Dr. Cates was a senior associate with the Lewin Group, a healthcare consulting firm where she focused on HIV policy, strategic planning, health systems analysis, and healthcare for vulnerable populations, among other prior positions. She directed the Office of Lesbian, Gay, and Bisexual Concerns at Princeton University. We are excited to hear your expert facilitation from our panelists and other experts today as well as tomorrow. So thank you, Jen. And for Dr. Patrick Sullivan, he is an infectious disease epidemiologist whose career in HIV prevention research and public health has included work in basic sciences to understand the mechanisms through which HIV causes illness, public health surveillance to document the epidemiology of HIV infections, and the health inequities in the epidemic, development and testing of interventions to reduce new HIV infections, as well as digital communications to increase the use of data to end the HIV epidemic. And lastly, implementation science to translate effective interventions into public health practice. His career and volunteer experience has spanned many organizations involved in HIV prevention and care. He has volunteered as an HIV counselor and tester at AIDS Atlanta and has worked for the Centers for Disease Control and Prevention and has worked in leadership roles in multiple NIH network science organizations and has developed and most notably led AIDSview.org, a public HIV data resource with over 500,000 users each year. Drs. Kate and Sullivan, I will turn it over to you.
Great. Thank you so much, Marlene, for that introduction. Hi, everyone. Jen Cates. On behalf of PACHA Subcommittee on Global Health, I'm my co-chair, Patrick Sullivan. Welcome to this session or series of sessions. We're really excited to have this series of sessions today focused on the U.S. global response to HIV and PEPFAR. Patrick and I have always endeavored to include in every PACHA meeting some discussion of the global epidemic, updates on PEPFAR, but this is really the first time that we are doing such a comprehensive overview, and there are several reasons for that. First, Marlene talked earlier today about our charter. In the charter for PACHA, it was one of the areas identified for PACHA to provide advice and information and recommendations to the Secretary. We are asked to provide information on global leadership in responding to the HIV pandemic and expanding access to treatment, prevention, and care for people living with HIV or AIDS around the world. So it's actually in the charter of PACHA to include the global epidemic. Second, given that PEPFAR is such an historic and unprecedented effort by any government to address a disease, an infectious disease, and you'll hear a lot more about that, we felt it was really important for PACHA members. Most PACHA members focus on the domestic epidemic, not on the global epidemic. And I know while some of us have been doing this for a long time, there are others who are newer to HIV and may not know the history. So we thought it would be quite important and timely to learn about the history here and how the US chose to do this work and what it has actually done and what PEPFAR has accomplished. Third, a big emphasis for PACHA, and this is for HHS and also the US government overall, is bidirectional learning. So the idea that we can learn both from what is happening around the world to inform our domestic HIV response, and our domestic HIV response can inform some of the strategies we may want to employ globally. We've always tried to include that in our work, and today really the part of the purpose of this is to have PACHA members hear about the work of PEPFAR and understand what that might inform, how that could inform the information that we are taking in to contribute to the domestic epidemic response. Those are the three top reasons. There's others. We have a terrific set of presenters and panelists. Really, we've reached out, and as you'll see, PEPFAR is truly the definition of the whole of government response, and we reached out to so many different agencies and operating divisions, and everybody said yes if they weren't on vacation, and including some who are on vacation. So we really are just so appreciative to have this level of engagement today. You'll hear who each of them is as we get to their point in the presentation. For now, I'm going to turn it over to Patrick. Thank you.
Thank you, Jen. I'll be brief, but just say as Jen said, the global discussion is always present in our PACHA gatherings, and we have a subcommittee that works on this. But I think it's exciting to have a meeting with this focus for me, because having worked on the domestic HIV epidemic and having worked globally, I'm really struck by how much we're all in this together. There were 1.2 million people acquired HIV in the world last year, 32,000 of those in the United States. So we are a small part of a global epidemic, and because of the activities that Dr. Cates described, we're really engaged and involved in the global effort towards prevention. And I think there are themes globally and in the US that are important to recognize, that elevate the value of having these discussions about and understanding the global response, which is that the global HIV response is characterized by uneven, unequal progress. among countries, within groups, and we'll talk some about that. Another common challenge is providing care and prevention in the context of HIV-related stigma and discrimination. In many parts of the world, homophobia and anti-LGBTQ laws, and realizing the opportunities of U equals U, which has already been brought up today. So I had the opportunity to attend the International AIDS Conference, which Admiral Levine mentioned, and there was just sort of evidence of these shared challenges everywhere. And part of the concept of bidirectional learning for me was saying, you know, like in the globe, we share common challenges with the awareness of HIV infection. About 86% globally and in the US, 86% of people living with HIV are aware of their status. We share challenges with viral suppression, with appropriate coverage of PrEP. And in many cases, some of the root common causes are lack of awareness among people who might benefit from testing or treatment services, geographic distribution, transportation, where services are located, and really consistently HIV stigma, PrEP stigma, homophobia, anti-LGBTQ laws, transphobia as common kind of structural barriers. So at IAS, I've been working a lot on HIV self-test kit distribution with colleagues at Emory and the CDC. We now have a national program where people can order HIV self-test kits to be mailed to their homes, which is togethertakemehome.org. We can try and post that. But I really tried to look around and see what was being done in the world to address these challenges with getting self-testing resources out to people. And really observed posters and talked to colleagues around the world who are doing really innovative things, who are using taxis to deliver prevention commodities, mail-out programs like the one we have in the US, combining those with stigma reduction efforts, peer educators. And it sort of reinforced for me that we're one world and we have a common viral epidemic, and we share a lot of the same challenges. And so by bidirectional learning, which Dr. Cates raised, we're really just trying to name that cultural humility to ask and to be curious about how others are addressing these challenges, creating structures through which information can be shared and received. And I think that this global awareness it happens, through PACHA channels, and is a really important component of our global response, which is to share and to come humbly to understand what others are doing. And I hope you get a flavor of that as we move through our program today. So with that, I'm going to introduce our first panelist in this section. Lois Pace is the Office of Global Affairs lead on setting priorities and policies that promote American public health agencies and interests worldwide. In that role, she's responsible for advancing U.S. international health agenda through multilateral and bilateral forums. Ms. Pace oversees HHS's engagement with foreign governments and international institutions, policymaking bodies like the G7, G20, the UN General Assembly, and the World Health Assembly. Previously, she served as the president and executive director of the Global Health Council, was also a member of the Biden-Harris Transition COVID-19 Advisory Board. And Ms. Pace will give us a welcome message from the HHS Office of Global Affairs. Over to you.
Thanks very much. Is my audio okay? Great. Well, I really appreciate you all having me address this group. It's even more important, obviously, that you all are coming together to talk about one of our favorite topics collectively, which is ending the AIDS crisis and ensuring that we are really working towards that 2030 goal of not having AIDS or HIV be the public health threat that it has been for decades. So just kudos to everyone here for all the work that you have done, all the work you can continue to do. To that end, we are internally grateful here within the US government. And I know that I join many of my colleagues, some who are here, some who are not, in just saying thank you. Thank you and expressing our gratitude. So as has been mentioned, I'm Lois, and I have the pleasure and honor of leading the Office of Global Affairs, which sits in the Office of the Secretary of Health and Human Services, Javier Becerra. We do a lot to try and coordinate our work across global health, including in HIV, and has been mentioned, including our work with the president's emergency plan for AIDS relief. So it's really encouraging to hear how you all are going to focus on PEPFAR as part of this conversation and a series of conversations as part of this session, and really look at where PEPFAR has been, obviously, in the history of PEPFAR, but also where it's going and the important trajectory of PEPFAR, and as it has been said, how we can work together as a global community to advance this effort, because we truly are all in this together. I'm someone who has a background in domestic public health. I have not only worked internationally, and as I've worked internationally and domestically, it just continues to be reaffirmed or reinforced how connected our work truly is. And frankly, the stakeholders understand this. You all get this. You live and breathe this every day. And in particular, people who are affected by or at risk for HIV know this themselves and in their core. And so it's really a matter of us catching up to that reality. I think that we talk about how we share experiences across our sectors wherever we sit. And ideally, I think we really reduce this gap more and more. And I know I've talked about this before, how we can actually blur the lines between our domestic and international efforts in a way that really serves the global fight. I also want to acknowledge others who will come after me from other agencies like the U.S. Agency for International Development, from U.S. Peace Corps, as well as from the Department of Defense, who I know will be addressing you all. And just to say, this is not obviously only about those of us who are in the health space traditionally defined, but really is a all of USG effort. And then within the Department of Health, I know we have representatives who've already introduced themselves, from obviously the Centers for Disease Control and Prevention, from NIH, from HRSA, our Office of Global Affairs, and other divisions. And so shout out to our HHS family. We are a big and broad family that is fiercely committed to this work, and in the spirit and service of the well-being of Americans, but also others around the world. I think just to explain more how we think about this work, I'll do two things. First off, really, I hope it's clear that our work within HHS and in our Office of Global Affairs is not only about health security and infectious diseases. I know that takes up a lot of our time. I know that takes up a lot of space, right? And we're not only talking about HIV, but these other competing issues and outbreaks, frankly, of mpox, of Oropouche, of dengue, and the like. And so that certainly keeps us busy. But we also very much care about health access, health equity, and the other drivers of health and well-being around the world, including advancing sexual and reproductive health and rights, as well as more broadly looking at disparities or discriminatory practices and understanding how we need to really show up for certain communities in particular and ensure we truly leave no one behind. So in our office and in our department, we really see global health as a pretty broad spectrum of issues, and we really attempt to work across the ecosystem and architecture in everything we do. I think we have an interesting position where I sit in our Office of Global Affairs as well, because we get to have a tie to the global work, obviously, the international efforts, but our domestic efforts as well. And we can kind of sit at that nexus of both. So when we talk about bidirectional engagements or discussions, when we talk about the importance of exchanges, that's pretty easy for people like me who wear both hats and whose job it is to actually connect those dots and build those bridges. So that's what we are here to do. That's what we aim to do, not only across practitioners or professionals, but across institutions, across corporations, and of course, across people who are feeling affected, who are being affected by or living with HIV. Again, those who live and breathe this truly every day. And speaking of those who are on the front lines, who are feeling this on a daily basis, I want to recognize all of the work that people have done to innovate on their own. So it doesn't take all of us convening in these meetings to acknowledge that. We know that these innovations, these exchanges are happening organically. And these convenings provide an opportunity to shine a light on those, frankly, and to really scale those. So whether it's around the uptake of PrEP, whether it's around the use of data, there's a lot of knowledge and experience already that has not been limited by, the formal engagement. So I just want to say that outright. But given where we are with the epidemic, both domestically and internationally, it really is going to take us coming together and being more intentional about those exchanges if we're really going to reach that end goal that we're all facing, that we're all really targeting. And that's especially because we do have a lot that's really bringing us under pressure as a global health community. I've already talked about human rights, and that's already been highlighted by others here, so I really appreciate that. But obviously, as I've said, we've had COVID, we have other outbreaks to contend with, and then we just have the way people are being taxed with other social, economic, or environmental issues. So whether we're thinking about climate change and migration, whether we're thinking about conflict, whether we're looking at individual or international economic issues and circumstances around debt and the like, our work is just getting that much harder. And so we're trying to be that much more creative about how we approach it, thus the conversations that you all are having today. I know we've had these conversations before as well, and I want to acknowledge the ways that our White House Office of National AIDS Policy, our Office of Infectious Disease and HIV/AIDS Policy, and others here have really tried to advance this bidirectional learning. I want to give a shout out to Dr. Cates as well, because I know that these are the types of sessions that she's tried to host, including at the AIDS conference. And then obviously Admiral Levine spoke very well to what we can do together sort of across these divides as well. So I think I will essentially close out there. I know that our work is guided by a number of technical experts and interagency committees that really are learning from you all as you come together. So thank you for all that you are offering us so that we can show up that much better as USG. And like others have said, we know that the focus of today is really going to be around PEPFAR, but we also know that broadly this is about all of the work that we do every day for people living with or at risk for HIV. And so very grateful for everything everyone here is doing to really drive those strategies and really drive that change so with that we can have a meaningful impact for everyone everywhere. Thanks.
Thank you, Assistant Secretary Pace, for that putting things in that broader context and for getting us off on in a good mindset. And hand things over to Jen to introduce our next speaker.
Yes, thanks so much, Lois. That was terrific. Really appreciate you taking time to be with us. So when Patrick and I were designing the sessions for today, we thought it would be so important to ground it in the history of the U.S. government's global response. What led to the creation of PEPFAR? What was going on at the time? And then how did that actually come about? Because that story is a very unique one, and I think helps explain a lot about PEPFAR today. So in thinking about who could tell that story, the main person that came to mind was Mark Dybul. Mark is, I think, I'll just start by saying he helped create PEPFAR. He helped implement PEPFAR. He ran PEPFAR. He also ran the Global Fund to fight AIDS, TB, and malaria. And he's probably I think the only person that has huge global health programs in the world. So he alone is has an unprecedented viewpoint on and perspective on this program. He's currently at Georgetown University, where he's the co-director of the Center for Global Health Practice and Impact, and also a professor in the Department of Medicine there at the medical school. But he's done a lot of other things. But today we've asked him to be here as the person who was there when this program got conceived of and created, and can tell us how to ground it in that history. Thank you so much, Mark, for taking some time to be with us.
Thanks, Jen, and Patrick and Lois, and to all PACHA for inviting me and for those participating. Also, special shout out to Tracy Carson, who's been there since almost the beginning, very close to the beginning. And I appreciate the opportunity to talk about the history because of PEPFAR, but in a little bit the history of HIV, because we're losing that a bit. So The history of AIDS in the world globally goes back to the 1930s as best we can tell. And there are blood samples from the 1959-1960 in Kinshasa, Africa. We believe it actually started in West Africa, but don't have the samples to prove it. We do have the blood samples going back to 59-60, and in fact, there was an outbreak in Kinshasa in the 70s. However, because of lack of global movement, it stayed confined a little bit like Ebola was and remains in many ways. The first case, as you know, in the US was diagnosed in 1981 of the current pandemic. That was in homosexual men or a man. The first case in Africa, the first several cases were diagnosed in 1982, 1983, not because they didn't exist, but because they didn't have the tests in Africa until 1982, 83, and predominantly heterosexual, which I'll come back to. You all know that HIV is nearly fatal in all people, although the time to death is different, and the massive stigma. And many thanks to PACHA and those of you on the call who have done so much to fight for programs globally, but also to fight against stigma at home and abroad. As you also know, by 1997 in the United States and Europe, we had demonstrated combination antiretroviral therapy as being effective, and by 2001, it was widely available in the United States and in Europe for those who required it. Most people were receiving it at that time, except for those who were limited in access by stigma or other issues. However, while many people in the United States and Europe were receiving therapy, 2/3 of the cases of HIV were in Africa. And in all of low and middle income countries, Brazil had a sizable epidemic, Southeast Asia and Asia, some countries, but really 2/3 were in Africa. In all of low and middle income countries in 2001, 50,000 people were receiving antiretroviral therapy, despite the fact that they had 2/3 of the infections. And nearly all of those were in Brazil through a national program. There were a limited number of people in Africa receiving antiretroviral therapy, largely people who were wealthy enough to pay for it on their own. In fact, entirely people were wealthy enough to pay for it on their own. To put in context what that meant, in the hardest hit countries, which were mostly in sub-Saharan Africa and deep Southern Africa, for example, in Botswana, 75% of pregnant women in some districts were HIV positive and were transmitting the virus to their children, of course, when they delivered. 75%. It has been said and is likely true that countries like Botswana, Lesotho, Eswatini, all of whom had extraordinarily high levels, 40 to 50% in some cases of their adult population were infected, would cease to exist because they only had 1 million or so people. Those would not be countries today, in all likelihood, if it weren't for the global intervention. It's hard to describe what it was like there. For those of you who are in San Francisco, New York, you understand how difficult it was being in the community. It's difficult to describe what it was like being in Africa in the early 80s and 90s, and certainly into the early 2000s. There were entire villages run by orphans because all the adults had died. There was no hope, and no one had any hope. Everyone, with good reason, assumed they and their families were going to die. And if that's your view, education, jobs, the pall of hopelessness is impossible to describe. But the numbers were frightening, including the 75% I told you. In addition, life expectancy was dropping by a decade in the course of a couple of years. Countries that had fought against malaria and diarrheal diseases and childhood diseases had increased their life expectancy, in some cases up to 60. They dropped to less than 50 within a decade because of one disease, HIV. And of course, the one of the things that is not understood, and we hear this misrepresented a lot, is the poorest of the poor were not those who were getting infected and dying. It was actually those who stepped a couple of rungs up the economic ladder. Nurses, heavily infected. Teachers, heavily infected. 50 to 70% of teachers and nurses in some countries were infected with HIV. Factory workers, people who are producing. So the productive and reproductive part of society, the 15 to 40-year-olds, were the ones hit the hardest. And the ones hit the hardest were those who actually were most significantly contributing to the productive and reproductive part of society, which is why our own Department of Defense and other national security agencies warned of a collapse of a continent, literally a collapse of a continent, because the economic fiber, the future, the 15 to 40-year-olds were being wiped out, which is of course different than most infectious diseases that tend to infect the very young and the very old. So it's a very unique virus, and the devastation is impossible to describe. Now, a few countries were trying to respond. President Mocha in Botswana brought together Merck, the Gates Foundation, and created something called HAP that started to deliver antiretroviral therapy. The Botswanan government itself, which had some money because of diamonds. You might have seen, Botswana just found the second largest diamond in the world. They had some money, and so they were putting it, because President Mocha, I know the country would cease to exist if they didn't. But it was small, and the time of PEPFAR was announced, there were about a few hundred people in the country on antiretroviral therapy. There were important efforts, some within the US government by the CDC. John O'Merman in rural Uganda partnered with an organization called TASO to deliver antiretroviral therapy by motor scooter. The Joint Clinical Research Center in Kampala, the capital of Uganda, was setting up, which was a private clinic, was setting up distal clinics, remote clinics managed by nurses that doctors would occasionally visit to deliver antiretroviral therapy to the people who could afford it. We're talking about hundreds of people here, thousands at most, that had access to antiretroviral therapy. John Kengasong actually published a paper when he was in Cote d'Ivoire that was part of what we presented to President Bush, which is a nice turn of history, a nice circle of history. But those few efforts were there, but they were few. And I think one of the most telling things about this is there was no original Millennium Development Goal for antiretroviral therapy. That was added later. But in 2000, the public health community and people stood on the floor of the General Assembly and said that people in Africa were not capable of providing the systems and could not have antiretroviral therapy, that we should just stick to prevention. And that was the prevailing view by far. Fortunately, the Durban AIDS meeting led to a lot of awakening. There was a lot of activism that was led, but I think it's striking that there was no original Millennium Development Goal for antiretroviral therapy, because people literally said we shouldn't even try. But there were some people who thought that was wrong-headed. There was a small number. Jen Cates was one of them. Many of the people on this call were among those, but many were on the other side, as the MDG demonstrates. In the United States and in the governments, in particular, the Congressional Black Caucus with Barbara Lee was very active and proposing increases in funding. US government funding in 2001 was right $500 million, almost entirely for prevention for global HIV/AIDS. There was a Frist and Carry bill that was circulating to increase it to $1 billion. The Global Fund was created. Depending on if you're Japanese or Italian or what country you're in, either in Okinawa or in Genoa, it was created, but there was no money in it. And that was supposed to be a global effort to respond. Kofi Annan and President Obasanjo of Nigeria were instrumental in pushing that, as was Mark Malloch Brown. But people were thinking in the $1 billion over a couple of years. People were not thinking massive programming globally. Enter President Bush in 2001 where things started to change. It's not well known that the administration, and by the way, I was a member of the Bush administration, but I'm a career person. Tony Fauci was my mentor. Drew Weissman, who just won the Nobel Prize, was my first supervisor, and we're still in touch. So I'm a career person like many of you on the call, but I moved into a political position, but remained actually a secondee from NIH and Health and Human Services through my time at the State Department, including as coordinator. But President Bush stepped on the scene, and they came into office with an agenda to deliver on HIV/AIDS. And people forget that part. They actually created a global HIV task force with Secretary Powell and Secretary Thompson of HHS as the co-chairs of that. As a result of that, in June of 2001, President Bush announced in the Rose Garden with Kofi Annan and President Obasanjo there, the first gift to the Global Fund of $200 million, and later gave the second gift of $300 million. Then 9/11 happened. But I think it's important to remember this movement was occurring before September 11th and before PEPFAR. And September 11th, the government, ground, and certainly the White House was very focused, but Josh Bolten, who was the Deputy Chief of Staff for Policy and one of the angels of PEPFAR, called people together and said, look, we had an agenda coming in. A lot of us have to work on what just happened, but we need to get back to it. So the task force resumed and sent a group, including Secretary Thompson, Tony Fauci, and others, to Africa. They came back very excited about prevention of mother-to-child transmission because it had been demonstrated that a single dose of nevirapine could reduce transmission by 50%. And they became very excited about that. So Tony asked me to work with Health and Human Services and as part of the task force to put together a plan to prevent mother-to-child transmission, which became the President's Mother and Child Prevention Initiative, which many people forget about, which was launched in June of 2002 in the Rose Garden. Tony and I thought we were done, went back to NIH. I remember thinking, this is great. Now I can go back to my day job. At the launch in the Rose Garden, President Bush, through Josh, pulled Tony aside and said, this is a good start. Now think big. So it was really President Bush telling all of us, we were all thinking in the hundreds of millions, a billion. He was thinking, come back. I want something big. He didn't like small ball, as he often said. His one requirement, as it was with the PMTC initiative, is don't come back and tell me how much money you want to spend, which is how we gauged development at the time. If you asked anyone what we were doing in health, education, agriculture, the answer would be we're spending X amount of money. It wasn't we were achieving X, Y, or Z. So he said, come back with what you're going to do, how you're going to do it, and I'll find the money. And so PEPFAR was born, which was launched in the State of the Union address in September of 2003. And since then, as you all know, it's grown. The original goals were 2 million in treatment, which at the time was 50% of those in sub-Saharan Africa who were required it by the definition then, 10 million in care, and 7 million prevent infections averted, which was estimated to be about 2/3, and to do all that in 5 years. The World Health Organization launched something 3x5, 3 million on therapy by 2005, within 5 years, but there was no money or anything behind it. This had slightly different goals because we were focused on 14 countries. And the reason we were focused on 14 countries is we also had the Global Fund. And so we became the largest contributor to the Global Fund as well. So there was the bilateral and multilateral pieces from the beginning. Why did it succeed and what were the original principles? Presidential leadership is principle. Without that, it would not have happened. I can tell you that. We actually counted, there were 77 presidential initiatives when PEPFAR was launched. I can tell you the president didn't know about probably about 75 of them. He took this one on and personally ensured it made it through the congressional processes, personally ensured the bureaucracy followed what it needed to do to achieve those goals. Without it, it would not have happened. The second major piece was bipartisanship. It was bipartisan from the front, from the beginning. President Bush insisted on that. That required compromise, including around some provisions of the original authorization that many people didn't want, including most Republicans in the Senate. But compromise was necessary. And the bipartisanship really had been completely strong until this last authorization, unfortunately. One of the things that contributed to that bipartisanship was all-in effort. So at the beginning, there was the traditional advocacy community, but we also had the faith community deeply involved. People of faith believe in service to others, which made it complicated on some of the sexual issues, but it made it essential in order to get the bills passed. And importantly, the private sector was very involved. Very engaged in stepping up. And, we as health advocates, when you go up and advocate, they get it. That's what our job is. But when people from the faith community or people from the private sector come up, that's different. And that was hugely important to having that bipartisanship. But what really drove the success was moving from how much money do you spend to setting targets, setting achievable goals, that 2, 7, and 10, and reporting twice a year on where we were at and where we were at in terms of projections, what we were doing to correct it. It was a data-driven, result-building-driven system, not a how much money do you have. And that has actually changed how we do development. If you go back, really, PEPFAR is in many ways what drove nationally and internationally that data-driven, results-driven response. And then another essential piece was countries in charge. You can do pilot projects through US government alone. You cannot do national scale up. And that's why the countries had to be in charge, and they had to be country plans. The final piece of that from a bureaucratic standpoint, which I think is important for some of your conversations, was to make all that happen within the US government required an interagency approach. When I was out doing work through NIH in Uganda, I went to a rural clinic, or rural community, where USAID and CDC were both doing HIV prevention programs. Neither USAID nor CDC knew the other one was in that village doing the same work that the other one was doing. The US ambassador didn't know, and certainly the country didn't know. PEPFAR was fully interagency, which is why we have the coordinator in the State Department, because the State Department will never implement large programs, but it can coordinate. We actually studied the central command for that. And use the central command method of that. But it had to involve HHS, including CDC, and at the beginning HRSA, which is still involved, and later NIH, had to have USAID, had to have the Department of Defense, especially early on, because militaries were heavily infected. And so DoD was a key part from the beginning. The Peace Corps, at the beginning of the Department of Labor, that faded. Basically, I think there are still 7 agencies of the US government that come together to make PEPFAR work, but state had to lead so that all would come together and the national plans would come through the ambassador, who could then work through the country, which helped us diplomatically, but also helped us get the programs done. The programs evolved a lot since those early days. The earmarks fell away, the bipartisanship remained. There was an evolution in how programs were done, which is natural. That's what should happen. Sustainability was built into it from the beginning. If you go back and look at the early documents, we actually studied the Indian health services and how programs were turned over basically from a bunch of white doctors like me to the tribal system across many different islands. And a treaty between the tribes and the United States government funds that is entirely run by the tribes. And that was our model, that's what should happen, but in 10 years rather than 50. Different administrations have different approaches to that sustainability. But I think an essential piece is that the systems had to be built to deliver chronic care medicine. And that has become the backbone of the health systems in the countries in Africa that the Global Fund and PEPFAR have been involved with, that delivered many things, that have been involved with Ebola, involved with the COVID response. It's that system response that was necessary because, unlike a vaccine or something else, you needed chronic care delivery for both prevention and treatment. And those systems are really there to allow that sustainability to occur. And there's no better person than Ambassador John Kangasong to do it. So we look forward to the future. That's a very, very brief clip of the history of 20 years of extraordinary effort by people in Africa who made it all work, people in the US government that was there to support them, and the US taxpayer that made it possible.
Thank you so much, Mark. That was amazing. It's hard to capture all of that, but I think, you, as I said, you're the one person who I think can. We have some time for questions for Mark from PACHA members here, and we have until maybe about 15 minutes for questions. If people have questions, raise your hand in the Zoom. If you are having trouble doing that, you can chat it and we'll read that out. But just to let everybody know, we will have a number of other speakers talking about how PEPFAR works today. So if your questions are more about today, we'll get to that. But if they're really about the history and how some of the bipartisanship was forged and the different communities involved, this would be the time to try to get that information because it's so valuable. Carol has her hand up.
Hi. Mark, thank you for that presentation. That was awesome. So much condensed into I don't know how long that took. I was spellbound. I'm with the Association of Nurses in AIDS Care, and I just want to point out that in 2017, we bestowed our Public Policy Award, which is the only award we give to a non-ANAC member to President Bush because of acknowledging his tremendous leadership and steadfastness in developing and supporting PEPFAR. At the Presidential Library, by the way, in Dallas, which is a lovely place if anyone gets a chance to visit. But my question is, I guess it's the $1 million question, or no, the $2 billion question. How can we get back to bipartisanship? I mean, how was that so? Well, obviously it was established because it was a Republican president too, and a good man. But what are your thoughts on how to get back to that?
Carol, it's definitely the big question. First of all, thank you for the award for the president, but thank you mostly for nurses have been the backbone of the response in the United States and definitely in Africa. So thank you for the work you've done. The simple answer is one that is true for this and for everything else. Have people talk to each other again. I wanted to ask Jim Colby, who was the subcommittee chair of our appropriations committee in the House with Nita Lowy going back and forth, what happened, because I could see over the 10 years I was there that bipartisanship was falling apart. And Jim said low airfares. I was like, what are you talking about, low airfares? He's like, we used to know each other. He said, look, I'm a chair of the committee, our vice ranking now. He's like, I don't know half of the members of my own caucus. I've never met them. People have to talk to each other. They always used to disagree, but they then talk to each other at the end of the day and find a place for compromise. And we were able to do that for 20 years. This last time really comes down to abortion. It was abortion that tanked the reauthorization, just like it got dragged into the Department of Defense reauthorization. So, Jen and I talk about this a lot. Sadly, I predicted the outcome of this reauthorization from the beginning and what it was that was going to bring it down. We've got to get people to talk to each other. And to be honest, we need people to go up and tell them this has to stop on the Hill, but more importantly, in their own constituencies. To have people go back in and tell them this has got to stop. These lives matter, and you've got to stop this. And they have to start talking to each other. There's no easy answer to this. It's person to person. It's the same way you overcome stigma and discrimination. The same way people have to talk to each other. They have to understand each other. You can agree to disagree, which used to happen a lot, but you just need to talk to each other. And there's no easy answer to that. And then we have to get the far right and the far left isolated as they have been, because the far left and far right, in my view, meet in a circle. They behave in the same way. They act in the same way. They're as untethered from data and rational argument as far right and far left are no different. They just disagree on the policy points. But it's the only way. That's not a good answer because there is no way. It's going to take a lot of work, and to me, it's going to take all of us telling them to stop.
Patrick.
Thank you so much. I'm feeling inspired. I think many of us are. And I want to follow on Carol's question, which was sort of where I started. But What do you think in terms of finding this common ground, what part of the motivation is humanitarian and about taking care of each other in the world, and what part of the argument is economic? And could that be a place where we find some common ground that prevention costs, but it's cheaper than the alternative? So how did that play in, and what do you see? Is there an opportunity to advance that line of thought?
The economic piece has been a through line. I used to get beaten up all the time for not just making humanitarian arguments. I'd make the economic argument, the security argument. People say, "Oh, this is just humanitarian. We can't pollute this." But that's not how you get bipartisanship. Mike Pence was a strong supporter of PEPFAR. I think the economic argument is an important one, but to be honest, it's very difficult to make these days because you're talking to congressional people in places, and people are asking, well, how come my Medicare and Medicaid isn't as strong as it once was? And you're spending all these billions of dollars because people think it's a lot more than it is. And I think part of the answer for me is long-lasting injectables. Even the strongest supporters, if you talk to Lindsey Graham, talk to Senator Coons, the first thing they'll say is, when is this going to end? How much longer do we have to keep? We're 20 years, that's something to celebrate, but why are we still here after 20 years? The long-acting injectables changes the calculus, because as long as there are many new infections, you also need to have new treatment. If you can use long-lasting injectables to reduce the infection rate to a reasonable level that is manageable by the countries themselves, then you don't have to pay for all that antiretroviral therapy anymore. And this is a little gruesome, but it's actuarial. Within 15 to 20 years, the people who have HIV now, most of them will die, and they don't need an antiretroviral therapy anymore. So if you can slow the tap, turn off the tap with long-lasting injectables, then you actually get to that point. And then the secondary piece is we need to do a much better job of, and the countries will engage on this, of transferring programs to them. First, programmatic sustainability, then financial sustainability. And every country's on a different path, but it's very possible to put together those plans. We started to do it when I was at PEPFAR. Eric Gooseby continued the work. Deb did, and now John's taken it really on. But you have to make the argument for why our investment today will lead to, in the future, we don't have to do it anymore, that it will be taken on by the countries and by the rest of the world. The security angle is a very real one these days, and I think we need to make it much stronger than we are. China and Russia are all over Africa, and we are losing that battle right now. PEPFAR is our shining example of what works there, and that can't just be PEPFAR. It has to be more, which is why John's work in the Bureau is so important, and the existence of the Bureau is so important. But the security angle, I think, right now is much stronger than the economic argument. But we've got to actually start showing, if we cannot show how over 10 years we start a tail down of expenditures, it's just going to get cut off. It's that simple. So the economic argument actually twists the other way. The security one, I think, is very strong right now. And the work John and Tracy and the others are doing, but it has to be with the Global Fund. You have to do it together. We have a technology that allows us to do that now. And if we don't do it, I don't see how we maintain not only bipartisanship, I don't see how we hold on to the strongest supporters we have now.
Thank you.
Paul.
Thank you, Mark. That was very amazing, and I learned a lot. Is this going to be a book? It's got to be, and it's got to be a book soon. And you've got to tell the story, because I think there are pieces that people in the movement don't know. And I was listening to you, not as a person who was there, but as a person who realized, boy, there's a lot of stuff I don't know. And so I think it would be very important to take a moment to document that. While I don't think we're ever going to agree about President Bush, I do want to know that the leadership he provided. And I am very, very interested in how to make him human in my life, because there's a lot of trauma associated with him. And so it's very interesting to me. And I think as I listened to everything that you were saying, I had to ask myself, the discussion about long-acting injectables was particularly interesting because it is something that my agency is grappling with right now in very profound ways, and about our fear that we're going to see the same divide in PrEP with these new long-acting injectables, where certain communities are going to really benefit from it, but other communities will not. And so I would love to understand kind of how you think it's going to change internationally, and how we can take that argument and bring it domestically.
All great questions, Paul. First on the book, Josh Bolton and Mike Gerson, before he died, have been trying to get me to write a book for about 15 years now. I think it has to be a third party. John Donnelly, who used to be at the Boston Globe, is actually working. He's in Bellagio right now working on one. But maybe I'll do one after his. I'll wait and read his. By the way, and President Bush knows this. He knows it full well. I was not a fan. I did not vote for him. I was embarrassed he was our president, and then I met him. And while I disagree with a bunch of his policies, which he's fine with, he has no problem with that, his values are good. And actually, Michelle Obama said that. She loves him. They disagree entirely on a whole bunch of things, but their values are the same. And I think that's a very important point on the bipartisanship. As long as your values are okay, you can disagree as much as you want. So, but I do think it's an important point that I judged someone before I didn't know him, because you don't get to know. On the long-acting products, I think there are a lot of people who want to take pills. They don't want an injectable. They don't want to have to come in. But in the African context, at least, and this might be true in segments of the United States as well, especially women who come in, at least a portion of them come in for long-acting reproductive health injections. You can provide two preventive things at the same time. And that's a great opportunity that we don't have necessarily in the United States. And because young women are among the most susceptible in Africa, that is quite an advantage. Also for LGBTQ and people who inject drugs and other stigmatized groups, taking pills can be dangerous to them. But if they can go to a clinic once every 3 months, that might be a way to reach them and protect them from societal harm, which is getting worse and worse in many parts of the world, including many countries in Africa. So it gives an opening in some ways that we wouldn't have otherwise. And now it's been proven that PrEP does work fairly well in Africa as well as other places, not surprisingly. People just have to take it. It's just there are many factors that prevent it that we can overcome potentially with injectables. The US is a little bit different, but underserved populations aren't and stigmatized populations aren't. And so there may be an opportunity but it will take a lot of education. It will take a lot of learning and a lot of intervention. But I think it's a huge opportunity. But what it does mean, to your point, is willing to spend money now in order to save over the future. And that's where we actually need mathematical models. We need to be able to show it, and we need to be able to demonstrate it by showing over a year, for example, that you start to see an impact from it, whether it be in a community or in a country, similar to the way we manage PEPFAR.
Thank you. I think we have time for maybe one or two more questions. Rania, you have a question?
Yeah, thank you so much for that talk back on the history of PEPFAR. Paul, when you said you need to write a book, that's literally what I was thinking. And what it reminded me of is, Mark, I have a consulting firm where I do health equity and racial equity, but before this, I was at Black AIDS Institute for a long, long time, where I was president and CEO. And I think of myself as I grew up under Phil Wilson. And some of the stories that you talked about are stories that I feel like I just know because he's talked about them so much. As a side note, he is working on a book because I think telling that story is so important. And I think that I don't know if we have in academia or within like the public health force overall, a real kind of retroactive look at what strategies that we use that were successful in responding to HIV as a template, as guidelines, as evidence for strategies to respond to epidemics that will come after. And so when I think about what you're talking about in the work that's happened with PEPFAR, I question, where's this documented at? And how do we use this in other public health threats? And so that is less of a question and more just a comment, I think, for us as PACHA, especially as we continue to move forward with responding to HIV. How are we documenting these lessons learned, especially as we have eras of folks who've been doing this work for such a long time, hopefully transitioning into retirement and to living a life of luxury and whatever kind of retirement folks want. So that's one piece of it. And then Mark, my question, I was grateful that you talked about Barbara Lee, who I know has been a champion for PEPFAR work. And I think in general that I can say that Black elected officials, Black Americans were 100% behind, I don't say 100%, but highly kind of influential in trying to push PEPFAR, especially in countries within Africa. My question to you is about what kind of capacity building happened to ensure that communities, particularly in some of these PEPFAR countries, built up leadership to be the folks who are leading that work. When I look at some of the PEPFAR nations now, I think there's extraordinary HIV leadership. And so I'm wondering if there's any intentionality of building that leadership and expertise in those communities that were being heavily impacted.
Yeah, thank you for your first one. It's great Phil's writing a book. We definitely need to, I would definitely be reading that. And the Congressional Black Caucus played a key role. It was very intentional to build capacity because, again, you had to be national scale up. And the only way to do national, and the thing about chronic delivery is, as you know, you need chronic care delivery, you need logistic systems, you need supply systems, you need epidemiologists, you need data analysts, you need data systems, you need data, you need logistics, supply, communications, and then you need leadership at various levels. Going down to the community, and the earliest work was done at the communities. That was one of the things we emphasized. You had to start in the community. That was the only way it was going to work, which is how Ryan White, that's how we started in the United States too. You have to start in the community and then it will grow. And there was actually a moment in ICASA in 2008, which President Bush actually went to in August, where those of us who'd been involved for the first, or 2009, you could see the shift that now Africans were in charge. All the way down. And when ministers of health now tell me, don't send me any more consultants, it takes me more time to explain to them what we're doing, and they have no idea what our country's like. So that leadership, building the strength at every level from the community through to ministerial is absolutely essential in anything you do. The one piece, and data-driven, results-driven, community-based, all of those things are lessons we have to learn, and we can learn from our own domestic response because that's how our domestic response started. And Phil will talk a lot about it. The one piece that's, and Jen and I and others of you were on every pandemic panel. I was on the international pandemic panel. Everyone looked to PEPFAR and said, how do we do this? The problem is the interagency piece was critical, and that is very difficult, if not impossible, to reproduce beyond something that's international. It's in the United States, you're not going to have a State Department coordinator telling every state public health official what to do. It doesn't work that way. And so that or the central command in the military, which we use as the example, which was created because we literally were fighting wars where the Navy and Army and Air Force didn't talk to each other. They in the same field of combat. But that's very difficult to replicate in a country, whether it's the United States or countries in Africa. So I would just caution that that's the complicated piece that makes it very difficult. All the rest are reproducible.
Thank you. We are almost out of time, but Jono, I'm going to give you the last quick question, and then Mark, you can wrap that up, and we're going to take a short
Jono,
break.
I didn't know you were on. I should have said I did mention your name. I did say Jono Murman. Sorry. And Becky Bunnell, too. She was on. Jono and Becky were critical. Without them, there wouldn't be PEPFAR. If it weren't for TASA, we actually showed a picture of those motor scooters delivering antiretrovirals to President Bush. He saw 7 slides. That was one of them. there wouldn't be a PEPFAR. John, I didn't know why I was asking him all the questions I was asking, but without those programs, there wouldn't be.
Thank you so much, Mark, for your words. And Jen, I will be a brief question and maybe a brief answer. Mark, we currently have a large Mpox outbreaks occurring in Africa, and a risk that it will spread worldwide, although not definite, prognostication. Any lessons from the development of community and governmental response to HIV that you would recommend for people who care about Mpox?
Get a PEPFAR for pandemics, including Mpox, and get it in place and actually pay for it and sustain it, and use PEPFAR as a base, which is why I think the Bureau was created, because it can be done. And in the case of Mpox, we actually have a vaccine. I mean, this is not, this is an easy one relatively. We just have to care enough to do it. So I think it's Mpox, but pandemic, broader in pandemics, and having been on IPPR, we're in worse shape now than we were at the beginning of COVID. But we have to take it seriously. What it will take to get there, I'm not sure. Sadly, it might take another, COVID-like disease, which could kill all of us. But this one should be easy. We've got a vaccine. You've got people on the ground. You've got them trained. You've got the ability to do things that we didn't exist in 2000. You helped create some of those programs. But all it's going to take is political will. That's it.
Thanks.
Thank you so much, Mark. And it seems like we could have this conversation for a lot longer today. So write your book, and maybe we'll have you back to PACHA to talk more. We are going to take a short break. I think just 5 minutes. I'm looking to Carolyn and Chloe will confirm that. Mark, I should say this to Lois, Mark, and Lois, and anybody else who's a guest today. Please feel free to stay the entire time, or if you have other things to do, go. But we just want to know, thank you so much for providing your expertise and insights. It's been a lot.
Thanks for inviting me, and thank you for all you're doing.
Thanks.
Doctors Cates and Sullivan, thank you for that first session. And yes, we take a 5-minute break. Folks, if they can come back at, we'll say 2:32. Give an extra minute. Thank you.
Produced by the U.S. Department of Health and Human Services.